Sí, señores, vamos a dar comienzo a la sesión, por favor. Gracias. Yo creo que cuanto más le bajemos, mejor.
Sí,
Yo lo pondría más abajo, aquí, porque ellos se mueven aquí.
el cable tampoco da
No
para
da
más.
para más. Joder, ya estamos buenos.
Cómics que eran What If, no sé si os acordáis alguno, eran como historias que podían pasar, ¿no? Y esto es un poco lo mismo. Imaginaos que en vez de un marcador, la prueba que va a detectar un cáncer de próstata es una prueba de imagen, ¿no? Esto que parece, todavía no parece una realidad, realmente, bueno, ha sido publicado un ejemplo muy concreto en Urology Case Reports por Sangeet Gay, con un señor de la compañía del ecógrafo que tenéis ahí fuera, que se presenta voluntario para una ecografía transrectal. Maybe I talk in English? I'm talking about the publication of Sangeet Gay in Urology Case Reports, where someone from the company Exact View was volunteer for a transrectal ultrasound with the micro ultrasound, and they saw y vieron una imagen que era un Primus 4. They performed then MRI, multiparametric resonance, and they saw that PRATS 3 en la resonancia. And then, it's a little bit like Spanglish. And, and then they perform a PSA, un PSA 4,1, and they went through a biopsy, Gleason 4+3. They did a prostatectomy with a Gleason 4+5. So ISUP 3, then ISUP 5. That's a good example of how an image can become a marker. No? So now you're going to talk about resonance, about multiparametric MRI, and then vamos a hacer tres ponencias sin preguntas de resonancia y luego las otras de microultrasound.
Thank you very much. Thank you, and I also want to thank the organizing committee for inviting me. So the next 15 minutes I will talk about MRI of the prostate. And when I started with prostate MRI around 15 years ago, the main question from the urologist was, what kind of stage is this patient? Is it T2 or T3 disease? Is the disease going through the capsule or invading into the seminal vesicles? Or is it contained within the prostate? Nowadays, a lot of questions are being asked by the referring physician, like where is the tumor located? Is there a cancer? What kind of cancer is this? Can we use MRI for active surveillance? Assessment of local or distant recurrences? And we can perform image-guided biopsies and even perform focal therapies. And what we also see is that there is an explosion in the number of MRIs we have to report as radiologists. And if you look in our institution, when we started 15 years ago, the numbers were very low, and nowadays we reach up to 4,000 MRIs a year. So the number of MRIs are really increasing. And that's not only in our institution, but also in other institutions around us. So what is multiparameter MRI? MPMRI gives information about the anatomy of the prostate and the surrounding tissue of the prostate using T2, biology using diffusion-weighted imaging, and vascularity. So using contrast-enhanced MRI to show the enhancing nodules. So T2 is the cornerstone of imaging. That's the most important sequence in prostate MRI. Diffusion, again, gives information about the biology, and contrast-enhanced about vascularity. In some institutions, MR spectroscopy is still being used. I will come back to that a little bit later. So T2, the cornerstone, information about the anatomy. You can nicely appreciate the zonal distribution. Could you dim the light, please? Is that possible? Oh, okay. Thank you. It's a little bit dark. So luckily the peripheral zone is always much brighter compared to the inner part of the prostate, the transition zone here, and anteriorly a very tiny area of anterior fibrous stroma. Quite often this area can be confused with cancer. You have to be aware of that. Another example, this is still with the endorectal coil. I'll come back to that a little bit later. And a large lesion visible in the left peripheral zone, which most likely also invades through the capsule to the neurovascular bundle. A lot of VPH is visible here, and that's also quite often confused with cancer. This is a nice overview of the MRI, starting at the base of the prostate, senovesicles, bladder, the central zone, which is on top, on both sides, most likely also symmetric, can also be confused with cancer. The central zone is also dark on the diffusion and also dark on T2. But if it's symmetric, it has a moustache shine, most likely it's central zone and no cancer. Only 1 to 2% of the cancers will originate from the central zone, whereas 60 to 70% of the cancers originate from the peripheral zone. Anterior fibrous stroma, very important, is always dark. And there's a lot of discussion whether we have to use dynamic contrast enhanced MRI because it's costly, can also be affecting the patient. We all have heard about the accumulation of contrast in the brain. But especially in this area, if it enhances, most likely this will be a cancer. Diffusion gives information about the biology, so the motion of the water molecules. So if you use a sequence, and if there's a cancer in the neighborhood, the space between the cells is limited because in new formation of new cells, a lot of cells are being formed, and the space between the cells is limited compared to the normal structures. So if you look at the image, in this dark area, there's hardly any motion visible of the protons. In other words, hardly any motion of the water molecules. In other words, most likely cancer. And we have shown, and also other groups have shown, that if you look at the ADC value itself, if you measure or calculate the value in that certain area, the darker or the lower the signal, the most likely you are dealing with a more aggressive cancer. It's nice, so this is in blue is the normal benign tissue, low grade, intermediate and high grade, but still you can see there's quite some overlap between the groups. Of course you can draw a line, but if you really want to be sure that you don't find any non-significant cancers, the threshold should be put very low, and still you will miss a lot of cancers. So we're still not there yet. Contrast enhanced MRI. There's a huge debate going on in the radiology field where we should use dynamic contrast enhanced MRI. In my opinion, still we follow the guidelines, but I think in the version 3 guidelines, contrast enhanced MRI will be not be advised anymore. MR spectroscopy, I don't want to spend too much time on that. A very advanced technique. You need very experienced radiologists and spectroscopists. So the question is it only for Ferrari drivers? I think if you want to use these kind of sequences or advanced techniques, you must be a very good driver because you need experience. So I wouldn't advise to use spectroscopy in your daily routine. The discussion about using T2 in diffusion or adding dynamic contrast enhanced MRI is a big discussion, and what we have shown in our multi-center trial, which will be published soon, is that if you look at the area curve for the peripheral zone, using only diffusion with imaging combined with T2, the area curve we can obtain in the peripheral zone is 0.93. If you only look at T2 and DCE, the area curve is very low, it's 0.72, and almost flipping a coin in the transition zone. So, in my opinion, a very limited value of using dynamic contrast enhanced MRI. There's a lot of discussion about the NPV of MPMRI. I think the latest study of Hash from London, they've shown in a PROMISE trial that the NPV is now 89% in this multi-center prospective trial. And I think that's also more reasonable than the very high NPVs which are being reported previously, which are most of them are retrospective studies. There is also a paradigm shift we've seen using MPMRI. We use detection, finding cancers instead of staging. We use the imaging findings to perform the biopsy using cognitive or fusion biopsy or even in-bore biopsy. We're heading to simple multi-parametric MRI or biparametric MRI. And we don't use any NRF coil or spectroscopy. And this may also be used to perform focal therapy. So what's important? I always compare it if you want to buy a house, location, location, location. That's very important. And that's the information you get from the MRI. You can also get some information about the aggressiveness, perhaps some tumor volume, T2, T3, bone and nodes. But for today, we're focusing on location, and that's the most important imaging finding you get from the MRI. An MRI, if you use diffusion, can be used as a biomarker. There's always continuously a debate between using endorectal coil, which you have to insert endorectally, or not using any endorectal coil. And I think, in my opinion, also what I see in the field is that hardly anybody is using endorectal coil anymore nowadays, because the scanners are improving, the sequences are improving, and also the phased array coils, which are put outside the body, on top of the body, are improving in quality. And it's also questionable if we want to see extracapsular extension, or at least minimal extracapsular extension, because I don't believe that we can see a 0.5 millimeter invasion into the capsule. We can see where the tumor is located, which is very important for you as a urologist, but we cannot predict if there's any minimal invasive penetration into the capsule. I think you're more helped if we provide information where the tumor is located, rather than providing minimal capsule penetration. Gross extension, of course, is very important, but that can be seen without endorectal coil. This is an example of I think that's a little mistake in the image quality here. There's a large lesion here in left peripheral zone. I'm not sure what happened here and happened here, but in diffusion was also very well seen. So what are the challenges of MPMRI? And that's also what I heard during the break, is that not all radiologists can do it well. And I agree with that. So we are an academic center, so we get a lot of referrals from outside. So we see a lot of MRIs which we reread. And I think 50% of them are of very good quality, but the other 50% are not good quality imaging. And if the imaging is not good, then you can imagine the interpretation can be very difficult. Therefore, also, we try to implement the PIRATES guidelines. I'm not sure what really happened with the presentation, but some parts are lost. They have been implemented globally nowadays. And the reason for that, and one of the main drivers, was that we want to try to speak one language. So if you look at interpretation and also look in the literature nowadays, you have Likert scores, you have PIRATES scores, you have just interpretation scores. And that's very difficult. If we want to compare our results with the center next door, then we have to speak the same language. And that's why we try to push the PIRATES into the field. Most of you already know that we have a 5-point scale. 4 and 5, it's very easy, of course. Then most likely, most of you will do a biopsy. The PIRATES 3, that is a difficult area. because what's the next step? Should we do a biopsy? Should we surveil? Should we do a PSA test? Should we do a biomarker or something else? That's still a lot of discussion going on. We also know from our experience that in a study of 1,500 patients, if you look at the PSA density and a PyRS-3, if the PSA density is less than 0.15, the chance of finding clinically significant cancer is around 1%. So that's already something which can direct us which direction we should go if we have a PyRS-3. Also, I am as a radiologist, I'm also interested how I do my reading. So what we also do in our institution, we look back and look at the numbers of PyRS-3 I call. So if it's 40% PyRS-3 in all the patients, then I'm not so happy, because then I'm not doing a good job, because that means that I'm uncertain. And also this uncertainty is also not good for you, because you don't know what to do. So we try to avoid a lot of PyRS-3, but if sometimes it's unavoidable, then you have to call the PyRS-3. Preferably I'm more like 1 or 2 or 4 or 5. Then you know what to do, but the PyRS-3 is very difficult. Now in the current version we still use the DCE, but I think diffusion and T2 gives you really the answer. Like in this case, very tiny lesion on the ADC map, and I didn't discuss at all the high B value, but the B 1400 or even higher are very essential, because that draws your attention to the certain area and the lesion. And as the chairman already started today, is that with a Gleason 7 on biopsy and a Gleason 9 on the histopathology after radical prostatectomy, diffusion may also help us to guide our biopsies, because we also know from the literature that if you biopsy the most aggressive part, so the lowest ADC value, then most likely you will hit also the most aggressive part within the prostate. I won't spend too much time on DC because of the time. A final case, 60-year-old male, 4 negative thrust biopsy sessions, PSA 22. Of course, hearing the previous talks about biomarkers, most likely we should also have done a biomarker before that, before doing 4 negative thrust biopsy sessions. Patient came in, he had a lesion on the left peripheral zone, was scored as a 4, diffusion. Is this restricted diffusion? Is it high on the high B value? I would doubt that. It's more a 2. And DCE, unfortunately the picture is gone, was called positive. And the final PyRS was a 2, and we did a biopsy and it was prostatitis. Coming to the end of my presentation, because some of the slides are gone. Oops. I want to conclude. That's something I really want to do. Give me 1 second. Can you start here? I'll leave it here. It's okay. Oh, you can see it here. Yeah. So to conclude, MPMRI is really a helpful tool. You also have to be smart when using these kind of advanced imaging tools. MPV is high, but what we really have to keep in mind is how can we educate our colleagues, get them to a certain level, to a certain standard. I know there's also discussion within the AUA about having certifications, about certain threshold, and also quality control using double reading, but I think that's still evolving. And with that, I want to end the presentation. I want to thank you for your attention.